tape. So I'm Mike Astion, Division Chief of Laboratory Medicine at Seattle Children's Hospital. I'm a Professor of Laboratory Medicine at the University of Washington Department of Lab Medicine. And today I'm going to talk about understanding autoimmune disease and the alphabet soup of tests used in their diagnosis and monitoring. So today I'm going to give you this is an overview lecture. So I'm going to introduce autoimmune diseases, trying to work more in generalizations, and then I'll talk about some of the specific diseases and syndromes, a little bit of the epidemiology. I'll spend some time on social aspects of autoimmune disease because there's a lot of people believe that they have these diseases when in fact they don't, and that's kind of an interesting social phenomena. Driven by laboratory testing. I'll explain why your laboratory testing for these diseases is increasing and will probably continue to increase because of Google and social networking. Then I'll illustrate autoantibody testing principles using the systemic rheumatic diseases as an example, with lupus being the prototype for the systemic rheumatic diseases, and I'll specifically talk about ANA testing, rheumatoid factor testing, and testing for anti-CCP. A little bit on trends and perspectives, and I'll conclude. So what are autoimmune diseases? The definition, I think that's one I got from my favorite place to practice medicine now. I used to use PubMed and a variety of things in the University of Washington Care Provider Toolkit, which is tremendous, gives you tremendous access to scientific databases and scientific materials, but now I just use Wikipedia. It seems to be more accurate, and I like to wiki everything. You can wiki. So this is from Wikipedia. Immunological destruction of tissues by the body's own immune system. And you know, in popular belief, lay people, non-medical people just view autoimmune diseases as the attack on oneself. And it's very complex. It's a very, very complex area of medicine. There's many different diseases. There's over 80 autoimmune diseases that have now been described. They're interrelated. If you have one, you're more likely to get another. They're very complicated interaction between the genetics and the environment, different triggers that set them off or cause flares. So the most common ones in the United States most common ones, probably autoimmune thyroid disease. Celiac disease is very common as well, and that'll be discussed in some detail, so I won't talk about it. Most of the 80, however, are uncommon. Some of them are primary. That means you get the disease and you don't appear to have anything else setting it off, some other disease, and some are secondary. So for example, the antiphospholipid syndrome, which will be talked about in quite a bit of detail, is often secondary. First, people have lupus. It's considered their primary disease, and then they also have the antiphospholipid syndrome. Sometimes they're primary, as I mentioned. Sometimes they're secondary to cancer. For example, paraneoplastic syndromes, secondary to cancer. And I'll talk a tiny bit about that. And like I said, unfortunately, it's a lightning strikes twice situations. Patients with one autoimmune disease are at higher risk for others. Now, these diagnoses take, many of them, not all of them, but many of them, especially the systemic rheumatic diseases, can take a long time to diagnose. So rheumatologists who diagnose a number of the diseases, especially the systemic rheumatic diseases like lupus, and rheumatoid arthritis, Sjögren syndrome, they have to be tremendously patient. And it can be very, very frustrating for patients because it can take years for things to declare themselves in a way that become clear. These diseases are usually diagnosed by specialists, but unfortunately, in the United States, they've become the domain of naturopaths and other alternative providers who really do not have the knowledge base to make these diagnoses, which are very, very complicated. And unfortunately, they've given the disease to a lot of people, these diseases to a lot of people who don't have them, using alternative methods and not using any kind of conventional testing technology. Celiac disease may be the worst case, where there's a lot of naturopathic places you can go to, and you just get the diagnosis without any kind of conventional medical testing. Use alternative means. So that's been a problem in terms of overdiagnosis of these diseases. In general, most if you or a loved one have an autoimmune disease, most of them should be diagnosed by a specialist, with the possible exception of autoimmune thyroiditis, which is so common. These diseases tend to have patterns of flares and remissions. and they're often treated by some form of suppressing your immune system, some form of stopping the attack on yourself. Now, autoimmune diseases are associated in very complex ways with circulating autoantibodies in general. So there's three kinds of autoantibodies. Pathogenic, meaning they cause disease. So I have a list of those in the next slide, so I'll defer talking about them. Those that are an effect of the disease, meaning they're an epiphenomena. You have the disease and then you develop these autoantibodies, and they're useful in diagnosis, but they're not causing your disease. So, if you look at all the antibodies to RNA polymerases in people with systemic lupus, they're probably not causing the disease, but they're an epiphenomenon, and they can be used potentially for diagnosis. And this occurs in many autoantibody disease. And then the most troubling aspect of autoantibodies is that some are naturally occurring. And those of you, by show of hands, how many people have suffered with the ANA-IFA test over the years? So a lot of you. So you'll notice that an ANA-IFA test is almost never really darkly negative, right? If we turned off, especially if you turn off all the lights in the room, you do it in a dark room, and you're at some kind of rich hospital that can afford like a mercury arc lamp, and you don't run it till it explodes at 600 hours, so it's nice and bright, everybody's a little bit positive. And the problem in the United States with ANA-IFA testing is if you don't use controls and you put in that new mercury arc lamp or some other new lamp, you tend to call things positive over time. So the false positive rate, and I'll show you some older studies that are classics, is very, very high. And that's because everybody has a little general stickiness to their antibodies, and then there's naturally occurring autoantibodies. And that makes for a bit of a diagnostic conundrum. And then these things tend to occur in higher titer in women. And so that means you can't just willy-nilly test for these autoantibodies, because if you test for enough of them, for all these different diseases, you're surely going to be positive for the autoantibodies. But most people with the autoantibodies, especially in low titer, never go on to get the disease. Never go on to get the disease. So these diseases, for the most part, are not defined by laboratory tests. Laboratory test is an adjunct, but it can be very, very complicated. So the interpretation of autoantibody testing is difficult, and autoantibody testing should be done very, very carefully and shouldn't be part of any kind of general health screening. And I'll go into that in a little bit more detail later. Of interest, though, and this complicates the problem, is that autoantibody, in almost every disease where it's been studied, so almost every autoimmune disease, whether it be, type 1 diabetes, lupus, the antiphospholipid syndrome, rheumatoid arthritis, when you take a person who has the diagnosis, so in this slide it would be at this point when they meet the criteria because they have the signs and symptoms, they have radiologic findings, whatever it is to meet the criteria for the disease. If you look back at banked serum on those people, if you're fortunate enough to have banked serum, the autoantibodies were present first. So this seems to be a general rule of autoimmunity, that the autoantibodies were present first. But the conundrum, this is the problem. So people say, well, don't you want to know? We should all get tested to find out. But most people who have these autoantibodies don't go on and get the diseases. That's why you can't just test willy-nilly. But it's interesting that they're present first. So the idea over time is, could you, using autoantibody testing and some other factors, is it possible to predict who will go on to get the disease? Now, if it were, then you could have some major public health interventions for major health problems like type 1 diabetes. And those kinds of studies are underway, but it's a very difficult area. Now, pathogenic autoantibodies are the ones that actually are associated with causing disease, and I list 4 here. Now, some of them are quite easy to understand. If you have the Lambert-Eaton syndrome, there's an antibody against anti-calcium. There's calcium channels in cell membranes, and it's an antibody that blocks that channel, and the symptoms of weakness, polyneuropathy, et cetera, are associated with it. In Graves' disease, there's an anti-TSH receptor antibody. It actually stimulates the TSH receptor. That gives you your symptoms. Systemic lupus produces all kinds of autoantibodies, a broad, brisk autoantibody response. It's not unusual for people to have, on average, during either a flare or initial diagnosis, if they have a fairly dramatic presentation. On average, they'll have 3, 4 autoantibody presence. Most of those are epiphenomena, but there's one, anti-double-stranded DNA, which is actually pathogenic, and the mechanism there is double-stranded DNA binding to its antibody and depositing. You get an immune complex deposition, and then the body responds to that to produce some of the characteristic findings. Myasthenia gravis, where you actually have an antibody to the acetylcholine receptor, it blocks the receptor and produces the characteristic findings. But most autoantibodies are not pathogenic. They're epiphenomena that can be used diagnostically. The ones I've listed here, as well as a few others that will be discussed today, some of them are epiphenomena, and some that will be discussed today are actually disease-causing. Now, there's more than 80 diseases and syndromes that can be classified as autoimmune diseases. And that's a very, very large number, and there's testing for a good hunk of those. And there's been a variety of classification schemes that have been used over the years to try to group these things, and none of them are perfect. This is a common one, which is to group the 80 diseases in 3 categories: systemic rheumatic diseases, organ-specific diseases, and this intermediate group associated with pulmonary renal syndromes. And the main problem with the classification is that many of the organ-specific diseases aren't really specific to that organ. They primarily affect that organ, but then these people are more likely to go on and have other organs affected or go on and get other autoimmune diseases. So that's been the main problem in classification. But I think for the purposes of briefly just showing you how big the list is, this will work. And it also gives me a chance to discuss in more detail some of the prototypical systemic rheumatic diseases, which is worth doing here because I'm going to talk about the testing for that. Because in terms of the high volume tests in your laboratory, outside of celiac disease, the high volume test in your laboratory in immunology is really driven by the ANA group. That's where the majority of that's the highest volume test in most clinical immunology lab are driven by the systemic rheumatic diseases. So your ANA group, your rheumatoid factor, and now your anti-CCP. So I'll talk a little bit more detail about systemic rheumatic diseases, and it also gives you a feel for some of the difficulties in this area of diagnosis. So with systemic rheumatic diseases, and ANA testing, so you take a history and physical, and then maybe these things are suspected. Now, at the family practice level, what the family practice or general practitioner is trying to do is send something to your laboratory and hopefully get a negative result so that they can move on to what the patient is most likely to have. Because in general, systemic rheumatic diseases are not that common in a family practice. They occur, but they're not as common. So if people come in with classic symptoms of a systemic rheumatic disease, which might be hair loss, fatigue, and some joint pain, most people, I have hair loss, fatigue, and joint pain. I have it every day. I don't have systemic rheumatic disease. So you can, you rule me out because I'm driving you crazy. I come in with this gigantic list of tests that I think I should have because I have a computer and it's connected to the internet. And a friend of mine told me about, some crazy website. And so then they want it just to be negative so that it rules out. And if it's positive, they're probably going to refer to a specialist. Now, this leads to a problem. So in the United States, the #1 reason for referral to a rheumatologist is a low-titer positive ANA test. And that is what your lab is producing, unfortunately. That's a problem. And then there's a shortage of rheumatologists. So the average age of a rheumatologist in the United States is around 500-600 years old. And which makes, for medical technologists and people, it makes us feel younger because they're actually the only group. Them and nurses and rheumatologists are the only 2 groups that are older. And so there's a shortage of rheumatologists. It's not the best paid specialty, and so their clinics get clogged with these patients when patients with the diseases who need to be treated by specialists. If you have scleroderma, you need to be treated by a specialist. And so it can be difficult for people who need to see these people, to see these physicians, to see them because we get clogged with these low-titer positive that turn out to not be systemic rheumatic diseases in most cases. So at this level, family practice, general practice wants to see a negative. If it's positive, they're going to get screened. But when these diagnoses are made, they're not based just on laboratory tests. So I want to distinguish sort of rheumatic diagnosis, and this applies to a lot of autoimmune diseases, not just rheumatic diagnosis, from other kinds of diagnoses that we use lab tests for. So rheumatic diseases, lab tests are just a helper, as opposed to, say, infectious disease, where the isolation of an organism literally is necessary for the diagnosis to be made. You can't have, you can't have AIDS, you can't have HIV without a positive HIV test. You can't have, chronic hepatitis C without having a positive hepatitis C test. If you have a heart attack, you have a positive troponin. Coagulation tests can be, coagulation disorders can literally, some of them can be literally defined by testing. That is not the case here. It's not like when you go to an emergency room and your lung is consolidated and you got a big fever and you huck out something green and you grow it on a plate and it's strep pneumonia. That is your diagnosis. That's not systemic rheumatic disease testing. That's not rheumatic disease diagnosis, and that's not the diagnosis in many of the 80 autoimmune diseases. What happens here is you have a constellation of signs and symptoms and you combine it with diagnostic testing, and in many of the diseases you do not need the diagnostic test to be positive, and you can still meet, in some cases, the criteria for the disease. So this is a difficult area, and most of the positives will turn out to be false. And so after the ANA screening test is positive, you have to do more. And one of the things that you have to do more of usually is wait. And that can be very, very difficult. For example, if a disease, if you need 4 criteria, or if clinicians are using the presence of 4 out of 11 criteria, or 3 out of 7 criteria, and you only got 2, and you're suffering, that can be very, very difficult to wait. Rheumatologic diagnosis is difficult, and autoimmune diagnosis in general can be very, very difficult. This is a list of the systemic rheumatic diseases. Lupus is considered the prototype. Sjögren syndrome and autoimmune dry eyes, dry mouth, progressive systemic sclerosis, dermatomyositis, pyomyositis, mixed connective tissue diseases, undifferentiated connective tissue diseases, and rheumatoid arthritis. And ANA testing is valuable for all of this, except for rheumatoid arthritis, which uses a different series of tests, which is the anti-CCP test and the rheumatoid factor rather than the ANA test. Now, another thing that's really troubling and difficult about systemic rheumatic diseases is that over the course, before the diagnosis is made, a tremendous number of patients fall into the category of undifferentiated. They do not have enough criteria met in the clinician's eyes to be called a specific diagnosis like lupus, but they're suffering. And so maybe they're called lupus-like and treated as if they have lupus, but you still have to wait. The other in some series, people estimate that as many as 30% of patients are at some point considered undifferentiated without meeting definitive diagnostic criteria. That's difficult. The other thing is overlap syndromes, where people have, look like they have pieces of 2 syndromes. So it's a very, very difficult area of diagnoses. Now these are 2 common phenomena in autoimmune diseases, which is hair loss and Raynaud's phenomena, 2 common findings. But unfortunately, most people with hair loss and most people with Raynaud's phenomena have Raynaud's phenomena. They have it. I'm not going to ask for a show of hands because of HIPAA. But some of you in this room have Raynaud's phenomena. And sometimes it can be so bad you got to move to warmer climates. But most people with Raynaud's phenomena don't get scleroderma, but almost everybody with scleroderma has Raynaud's phenomena. So you can see why that would lead to a problem if you are a Googler. Because scleroderma is a very, very difficult, frequently fatal, disfiguring disease. And, it's not something you want to even have in your mind. So back, in my grandparents' day, when you had Raynaud's phenomena, they'd say, oh, I got a little bit of this, what happens? I go to Florida, I'm okay. Now they say, oh my God, I'm going to get scleroderma. And you commence to worrying yourself to death. That's, a problem. So lupus is the prototype. It's a multi-systemic disease with variable presentation and course, and it commonly includes arthritis, rashes, and rashes, and sometimes especially in the bad cases, the cases that are fatal involve renal involvement and neuropsychiatric disease. Those are the most difficult aspects of it. But many people, it's variable. Some people get lupus, they live for 60 years. Not uncommon. You die of something else. Some people have lupus, they're dead in a year and a half. It might not be one disease because its manifestations are so different in different people. And I'll talk about why that might be or speculate in a couple of minutes. There's a positive ANA. If you press hard enough over the course of the whole disease, the ANA is almost always positive. Now, in any one presentation, this number falls into the low 90s in terms of sensitivity. But over the course of the disease, if you press hard enough, you will find a positive ANA. The antibody response is broad, especially if you have a lot of symptoms at presentation. On average, you get 3 of the 7 commonly tested antibodies, and there's more than that usually present. But we don't test for all of the 75 autoantibodies that have been found in lupus. But of the common ones, it's not you have 3 out of 7 for people with an active presentation. And the markers that are more specific for lupus are Smith and double-stranded DNA, and double-stranded DNA is pathogenic, so it's part of the disease causing in lupus, especially in patients with renal involvement. So this is the criteria. In the United States especially, the American College of Rheumatology classification criteria are important, and even though they're the classification criteria for research, the fact is they strongly influence diagnostic practice. And what you see here is a list of 11 criteria, and if you have 4 present, you can be classified as having lupus. And you'll notice that hair loss isn't in there, even though it's one of the most common presenting features of lupus. Fatigue, another extremely common presenting feature of lupus, is not in there. Why not? Because these things aren't differentiating. They don't help you in the diagnosis from the point of view of differentiating it from the 4,000 other causes of fatigue and the most common cause, which is being alive. So you see here the things that differentiate it, where 4 out of 11 things can differentiate it. You'll see that the first 3 are things that you might see in a dermatologist's office. And in some cases of lupus that are mild, often the dominant finding are the skin findings, and people don't have much more than that, so-called cutaneous lupus. But malar rashes, discoid rashes, photosensitive rashes. Another thing that you see in a dermatologist's office will sometimes be oral ulcers. So 4 out of those criteria: arthritis, serositis, the renal disorder. So the 7 and 8 are particularly problematic, and in people who have very poor prognosis in lupus and who have to be treated much more intensely, you'll often see criteria 7 or 8. And you'll see you don't get down to lab tests until 10 and 11, positive ANA and double-stranded DNA or Smith. And so you can have ANA negative lupus. It's possible. All these criteria aren't equal because it's very rare to have ANA negative lupus, but you can have ANA negative lupus. And you frequently have double-stranded DNA or Smith negative lupus. Those are specific findings, but they're not sensitive. So that is some diagnostic criteria. It's actually slightly more complicated than that, but I'm simplifying from the point of view of an overview lecture. Sjögren syndrome is an autoimmune dry eyes, dry mouth. This is a gal with an inflamed parotid gland from autoimmune infiltration. If we took out her parotid gland and took a look at it, you'd see all kinds of inflammation, lymphocytes, etc. This is a fairly common autoimmune disease, especially mild versions of it. And the lab tests that are frequently positive are ANA, SSA, SSB. But just to show you how crummy this area of testing is, most patients, a tremendous amount of patients with Sjögren syndrome have positive rheumatoid factor. So here's people who frequently present with arthritis, and they have Sjögren syndrome, but they have a positive rheumatoid factor. So do you think some of these patients are misdiagnosed and mistreated? Yes, and that's why they need to be seen by a specialist. You don't want your, Marcus Welby. I mean, I love my family practitioner. I go to see Granny from the Beverly Hillbillies. She's my, remember Granny from the Beverly Hillbillies with the jug? She'd come in, she'd talk about the rheumatism and give you the jug with the 3 X's on it. But Marcus, well, that's a good doctor. It's the kind of doctor I could sit down with and have a good session with. But you don't want to go to a general practitioner to make this diagnosis. You want to get referred, and you can see that these things are misnamed. Sjögren syndrome A, Sjögren syndrome B. If you take all the people in the world who are sick, and if they're sick and they have Sjögren syndrome A, you're more likely to have lupus than Sjögren syndrome. So these things are misnamed. The most misnamed test in laboratory medicine, the one with the name that deserves it least, is rheumatoid factor. Because if we had it, what happens is there's a study done, who knows how many years ago, decades ago, and you measure some patients who have rheumatoid arthritis and some that don't. You think, oh my God, this thing's very specific. Look at this. So you publish in the New England Journal of Medicine. Now over time, it's an absolute law of medicine that the specificity of a test will decrease over time from the time it's discovered as time progresses. So specificity means the probability that you'll test negative given that you don't have the disease being tested for. You wish everybody who didn't have the disease being tested for is negative, but unfortunately we have false positives for a lot of reasons. Lab errors, overlap of disease and health, etc. So the specificity of a test declines over time after its discovery. And so rheumatoid factor is discovered, it's, oh, yippee, rheumatoid factor. We got a test for rheumatoid factor. Now, if that thing was renamed now, knowing what we know now, first of all, we might have to call it the test for hepatitis C. That's number one. And number two, we really should call it the crappy test that turns positive for no reason. You got a cold, you got a Sjögren syndrome, your in-laws are in town, you ate at a new restaurant, you don't like your new boss, boom. Rheumatoid factor's positive. So these tests now they're misnamed. Sjögren syndrome is misnamed. And this creates a problem with the public. If you tell a person, if you tell my aunt that you have, here's your test results, and you have Sjögren syndrome A, she gives it to her daughter, and they get on Google. I mean, is it possible to have any diagnosis besides Sjögren syndrome? The next day when I see my aunt, she'll be puffing out her cheeks. She'll look like a chipmunk. She'll stuff nuts in her cheeks. She'll start walking with a limp. She'll have dry eyes and dry mouth. She'll be walking around like, and that's what goes on in American medicine. So these things are often, they're misnamed. We're better off with Roe and Law. We're better off when they were named after patients because the specificity decreases over time. In the pharmacy, we have the exact same thing going on. In pharmacy, the side effects of a drug increase over time, right? It's released, like when I was in medical school, I remember I had terrible allergies, and this drug came out, Seldane. Does anyone remember Seldane? Well, Seldane became the leading drug. It was the leading selling drug in the world at one point. It was like the first billion-dollar drug. And I'm, so happy because I'm not falling asleep in lecture, and I'm just gobbling this stuff down. And then boom, because it's got no side effects. It comes out, no side effects, because side effects before that, you used to have to take Benadryl. You're falling asleep through medical school. I'm getting like D's in medical school. That and a fear of touching people led me into clinical pathology. And then this thing comes out, and then boom, like 2 years later, say, oh, there's a side effect. We're pulling it off the market. And I'm thinking, there's a side effect. You get a funny, you get a rash on your toe or something. I'll keep taking it. And the side effect, does anyone remember the side effect? Cardiac sudden death. And that's pretty severe. It's not common, but it was pretty severe, so I had to stop taking it. It's disappointing, and your nose is running the next 5 years. But the side effects of drugs increase over time, the specificity of lab tests. So when people come out and tell you, this is a specific lab test, we just discovered it, we got this study where we took 4 people here and 18 people here, that's misnamed. That's misnamed. And I'm sure you've had this in your lab where paper comes out and then a physician calls you and says, when are you going to have it online? Yeah. I got a form letter for that. I developed a form letter for that. It's beautiful. And it's long. It's just about like the history of lab testing and how hard it is for lab testing to climb the ladder and actually become a clinical lab test. That there's a difference between two populations that don't overlap that much for this test, and then it becoming a lab test, and how most tests don't make it. And it's very, very long, and I sent it for years, and everybody thought it was the greatest letter, and people would be borrowing it. And then I sent it to someone when B-natriuretic peptide came out. Like, this test's never going to make it. You know, just you're a jerk, you're an idiot. And then, you know, now it's an unbelievably popular test. That guy still rubs it in my face when he sees me. He was the head of family practice for a while, and I'll see him in the hall, and he'll be like, Mike, B-natriuretic peptide. You know, like that, yeah, that stuff. So now I don't send that letter anymore. So I talked about Sjögren syndrome, I talked about lupus. Progressive systemic sclerosis is more severe disease. There's a couple of variants, though. One is less severe. That's the CREST variant, and most of you who do autoantibody testing are familiar with it because it's associated fairly specifically with anti-centromere antibodies. So anti-centromere antibodies are important to be able to identify because you're giving people a better prognosis, and that matters. And they're also important diagnostically. Here's two findings on your right with people with Scleroderma. One is it's hard to see, but the very characteristic findings on their fingertips: tightening of the skin, deposition of collagen. They get this pitting on their fingertips. And then Raynaud's phenomena, which is not diagnostically in the criteria, but very, very common in Scleroderma. I list some of the lab tests associated with Scleroderma. And what's interesting with Scleroderma is that now here you have many patients with Scleroderma do not have a positive ANA, even though it's in the criteria. The sensitivity starts to drop. So whereas the sensitivity for lupus of the ANA test is in the 90s, you know, in Scleroderma it drops down into the 70s. So there's plenty ANA negative Scleroderma. In the worst variant, you see anti-SCL70 topoisomerase antibodies, and then the anti-centromere in the better variant to have. And then there's a whole bunch of other antibodies, and many of them are associated with the anti-nucleolar, which is that, for those of you who do IFA like we do, the sort of bear paw kind of patterns. And those are associated with a bunch of specific autoantibodies that are epiphenomena rather than, currently considered epiphenomena rather than disease-causing. So my main teaching points about systemic rheumatic diseases is that they're based on a laundry list. And testing is important, but it's not the only thing. And one of the biggest problems we have is when non-specialists overinterpret those laboratory tests. And it's actually one of the main problems that a company like Bio-Rad would have too, because, you know, physicians who are not particularly skilled will often say, you know, why is my test slightly positive when the patient doesn't appear to have the disease? And of course the right answer is, why are you testing if you don't think they have the disease? So laundry list, and autoantibodies are usually present before clinical onset, and ANA testing is a screen for a good hunk of the diseases, but it can be a difficult screen to use. Now for a couple slides, I'm just going to go through a list just to give you a flavor for the world of autoimmune disease. I'll just list some of the organ-specific autoimmune diseases, and for those of you who do LKM testing and these kinds of testing, primary biliary cirrhosis testing, you're familiar with some of these tests. There's, you know, there's actually more than 3 kinds of autoimmune liver disease. I list 3 here. There's a bunch of things that affect the gut. Celiac disease will be discussed in quite a bit of detail. Renal involvement, the renal Goodpasture syndrome. Some of the more interesting ones affect the nervous system. I mentioned the Lambert-Eaton syndrome, which often arises in patients with small cell carcinoma of the lung. So it's considered a secondary autoimmune disease, and what's interesting about it is it has a pathogenic autoantibody. Why patients with this particular cancer develop an antibody to calcium channels is much speculated about, but these paraneoplastic syndromes can be very, very difficult to have, and it's really a terrible thing, a tragic thing. You know, you already have cancer, and then you get one of these terrible syndromes. It's one of the worst areas of medicine as far as I'm concerned. There's a couple of skin diseases I mentioned. Myasthenia gravis would probably be the prototype for an autoimmune disease that affects the muscles, and that one is pathogenic antibody against acetylcholine receptor. And then there's the vasculitis group, which is kind of an interesting phenomena socially as well. So Wegener's granulomatosis, I mean, lupus is relatively uncommon, but it's commonly tested for. But Wegener's granulomatosis, I mean, that is in the rare disease category. It's unlikely that anybody in the room has Wegener's or even knows somebody with Wegener's. It's not unusual for primary care practitioners to never in their entire career see a patient with Wegener's granulomatosis. Same can't be said of lupus. Most people in the room, there'll probably be someone who has it or knows somebody with it. It's commonly tested for. So here you have this disease that's actually quite rare, and the testing growth has just been unbelievable. This thing has been a tremendous revenue generator in our lab. And why is that? And this is the kind of thing that couldn't possibly rise to this level of testing without social networking and Google. And you know, when you have a runny nose, you usually have a runny nose, like an allergy or some form of rhinitis that's common, like a virus. You probably are not going to develop this debilitating, fatal if untreated disease. But unfortunately, you know, if you have pulmonary signs or pulmonary renal signs, you got to rule it out now. So you get this testing, and it's very important for people with the disease, and can be actually most of the time with autoantibody testing. Most of the time, it's not from a patient safety perspective. It's not the test that leads you into court. Okay, it's unusual. Troponin is more likely to land you in court, or things done in acute testing. But Wegener's is an unusual one because sometimes the patients are too sick to have a definitive biopsy of their lung, and so the ANCA tests can actually be critical in the diagnosis. And it is critical because if you don't diagnose a patient with Wegener's, they can have this florid pulmonary renal syndrome. It can be disfiguring. You can see pictures in medical textbook, people losing part of their upper airway. You can lose your nose, and so it's fatal if you don't treat it. And if you misdiagnose it, the treatment is fairly toxic and immunosuppressive, so there's a bunch of case series of people who actually had infectious diseases and false positive C-ANCA results, and they were treated with immunosuppressants. So if you have immunosuppressants plus infectious diseases, and those patients died. So this is an unusual and interesting area of testing, and what I usually recommend is that people don't do ANCA testing unless they have it in some volume, and that they be willing to refer their positives for either a second opinion or make sure it's positive by a second method. And that's in fact what the international consensus statement on ANCA testing, which has been around since the mid-90s and has been ratified a few times, states that you should have two methods because it's an unusual area. All right, what causes autoimmune disease? Of course, the answer is we know a lot, but it's hard to put it all together, and some of our experts this afternoon will probably go into more detail in their specific diseases. I'll just talk in general. So these are multifactorial. There's clearly a role for gender. I'm going to show you in a couple slides how much more frequent these diseases are on average in women. There's a role for genetics, environment. The role for each of these things in the diseases is very variable, and as I mentioned, the diseases may not be, lupus probably isn't one disease. So there's a role for environment, there's a role for genetics, and normally, these things affect your immune system, and you usually produce a brisk and wonderful normal immune response, okay? And then, people have natural autoantibodies, so there's some sort of light autoantibody response. It may serve some important purpose that's debated, that may be involved, or it may just be an epiphenomena in some cases, but in any event, this is what, a way of looking at it. And it's hard to distinguish in autoimmune diseases what is a trigger. For example, in a patient with lupus, they can go out in the sun and it can trigger a flare, or they can be stressed out. Wedding, divorce, death of a loved one, boom, lupus flare. What's a trigger versus an infectious disease can be a trigger. You get a cold of some sort, you end up with an autoimmune disease like Guillain-Barré syndrome. So what's a trigger and what's a cause? When is the infection, the cause of an autoimmune disease? Or many drugs can trigger autoimmune disease. Can they cause autoimmune disease? Diet, nutrition, pregnancy, sunlight, stress, other diseases. So it can be very tough to distinguish. And in many cases, you can't distinguish something that's exacerbating versus something that is causing. Oh, sorry. And then, so this is a normal autoimmune response, very light. And then in patients with autoimmune diseases, it's out of whack. It's too much, and you start to attack yourself. And I'll just use lupus as a prototype again, and like I said, our other speakers will speak about their areas. So just looking how complicated this can be, if you look at just the environmental factors sometimes associated with lupus, there's over 350 drugs that have been associated with lupus. over 350 drugs. Drugs can certainly be a trigger, and then drugs can be a trigger for a disease which is, lupus-like, a drug-induced lupus, but may not have all the full-blown symptoms. There's increased risk with oral contraceptions. There's a big debate about infection as a trigger versus cause. Most people think it's a trigger, but there's still a group out there that thinks that certain viruses are a cause of lupus. A number of different organisms can act as these triggers. There's a whole, just as an illustration, there's a whole literature on lipstick usage in lupus. For a long time, there was a thing about breast implants, silicone breast implants in lupus, which has kind of fallen by the wayside. I think larger studies have largely disproven that, although, plenty of people still debate it. And there's an increased risk if you live in urban areas. So it's just some factors. And then the genetics are very complicated. In almost all the autoimmune diseases, there's not a single genetic factor. There's multiple genetic factors. And if you look at, say, 30 genes associated with a particular autoimmune disease, they separate into high, medium, and low risk. And this is a very good reason not to have genetic testing. There's a whole group of laboratories that are starting to flourish in the United States, giving you genetic risk profiles. You don't want to know these things. Because no one knows what they mean. No one knows how to interpret it. If you have a medium risk gene present for lupus, why do you need to know that? You have no idea. And that has to be interpreted in the context of all of this stuff. If you live in the country and who knows? So you don't want that testing. Obviously there's a few areas in medicine where genetic testing is very helpful, in breast cancer, a few other areas. But still, even then you should meet criteria to have those tests. Otherwise, the harm from those tests outweighs the benefits, especially with the single biggest medical problem in the United States today is worry. People just literally taking themselves out of the game with worry. Like a lot of my friends, they're out of the game, and they have the same story. The painter came over and painted, and I've never been the same since, or the exterminator came by, and I went and saw a naturopath, and I sent these tests to this lab in Texas, and I have 17 nutritional deficiencies. I'm not getting enough selenium. My chromium is off. I may have been exposed to beryllium, even though I don't work in an atomic energy factory. And then that's it. They're out. They're out. They got the foot in the sand. They got the symptoms. They got the foot in the sand, and then boom. Just walking like this the rest of their life. They're out. And it's tough for me, and I try to talk them out of it. And I'm like, why? Well, they're like, why are you trying to talk me out? Why do you think I got nothing? And I say, I need to talk you out of this because I want to put my foot in the sand. I need you to stay in the game so that I can stay in the game. Like in my house, to get out of a chore, you would have to, I got 2 kids, 2 cats, older parents, all kinds of problems. All kinds of problems. To get out of a chore in my house, you have to be sick. Like you'd have to have a limb fall off. If I told my wife, I don't feel well, I'm going to take a break. I'm going to go watch, King of Queens repeats for 2 days because I got a cold and my back is killing me. She's like, what are you talking about? Like if my arm fell off, if I had a grapefruit-sized tumor growing out of any orifice, she'd give me a break. And I feel the same way about her. You got to show, there's got to be blood. There's got to be spontaneous hemorrhaging, something unusual. You got to lose an organ. So don't tell me about the painter coming over or that you had chromium testing and you're out of the game because you had your chromium test. You don't need your chromium test. So you don't want these, you want to stay in the game. You don't want these tests. But I'm letting you know about these things so you know that it's complicated. So there's 30 to 40 genes conferring varying risk from low to high. And if I was presenting the same slide for diabetes, I could say the same thing. The genes will be different. Actually, some will overlap. The genes would be mostly different. But this would be the same if we presented it for any autoimmune disease. So there's, a good example of a high-risk gene is congenital C1q deficiency, and that's very rare. So some of the high-risk things are very, very rare. You shouldn't test for them. There's some specific genes in HLA region, chromosome 6, that confer risk. That risk is commonly low. Obviously, there's a difference in men versus women, so there's something genetic there. There's particular predisposing genes in women, and some are involved. The relationship between hormones and autoimmune disease is unbelievably complicated. And obviously, and each of those hormones is under genetic control. So it's a very rich, environment. And you can see why this, why would it be, it should be a disease with many different manifestations. People shouldn't be the same because people are different. And in terms of, straightforward examples of triggers, causes, people with Guillain-Barré syndrome following usually follows some sort of viral infection. And I mentioned small cell carcinoma of the lung and paraneoplastic autoimmune syndromes. This is the autoimmune diseases, including the most common autoimmune disease in the United States, Hashimoto's thyroiditis. Most people with, who are hypothyroid in the United States, it's caused by an autoimmune disease, Hashimoto's thyroiditis. It's treatable by, in this case, we treat with replacement. But look at these ratios. Tremendous number of women relative to men get autoimmune disease. And for most autoimmune diseases that have been studied, this is the case. The most complicated thing of all is the relationship between pregnancy and autoimmunity. And if you think about it, it makes sense that this is complicated because when you're giving birth or when you're carrying a baby, when a woman's carrying a baby, I mean, this is a foreign body. This has a lot of components on it. This baby has a lot of components on it from your husband, who you probably shouldn't have married. He's bringing all these foreign things. I mean, it's very symbolic of the whole relationship. He's bringing all this foreign stuff into your body, and now you got to decide that you're not going to react to it, or you got to turn off the immune response to this conceptus, right? You have to just, this is just like in a marriage. You got to decide that you're just not going to react to everything I bring into the house. I like to drink milk directly from the carton. I leave the socks all over the house. I like to sleep with the cat, These are things you gotta just deny these things. So pregnancy and autoimmunity is a very complex relationship because pregnancy, as I mentioned, is immunologically unique, bringing a lot of foreign things into the circulation. And of interest, pregnancy doesn't have one effect on autoimmune disease. So there's a bunch of papers showing some improvement in rheumatoid arthritis, and then there's a debate whether pregnancy exacerbates lupus. And it's not an easy debate to resolve because there's stress in pregnancy, there's all kinds of other factors, but it's a very complicated state. Of interest also is that some things about pregnancy are more direct. So one of the biggest issues in pregnancy, and I'm sure the speaker is going to talk about antiphospholipid syndrome, is going to talk about this, is the passive transfer of maternal autoantibodies. So let's say the mom has lupus, or the mom may not have lupus, but she may have antiphospholipid antibodies. They're associated with fetal loss. So when you do a workup on a woman who can't get pregnant, this is part of the workup, is to look for antiphospholipid syndrome. And for women with lupus who have anti-SSA or anti-SSB antibodies, when those cross, they can actually cause a neonatal lupus syndrome, and in the worst cases, you can get death from neonatal heart block. And so you have to treat in these cases. So this is more of a direct effect, a passive transfer of autoantibodies that cause a poor outcome. But it's an important aspect of pregnancy, and obstetricians have to learn to manage this, often working in collaboration with other specialists. I want to talk a little bit more about social factors. I've referred to them a number of times, but I'll try to put it in a more systematic context. So why are too many autoantibody screening tests ordered? Now, before I go into this, I don't want to over-represent my opinion. So my opinion is that lab testing is unbelievably helpful for sick people. It's tremendously helpful for sick people. If you have cancer, you're going to need lab tests. If you have transplant, if you're transplanted, the lab is an unbelievably important part in saving your life. We're going to monitor your therapeutic drugs. We're going to look at the way your organ functions. We're going to chronically monitor any infectious disease problems you have. If you're sick, lab testing is very, very important. But what do you do with most human beings also have vague symptoms of daily living, and this has led to a tremendous amount of testing in a number of domains, autoantibody being one domain. Nutrition is another domain. Over-testing and allergy is another domain. And then over-testing of things that you need. So instead of ordering like a lipid panel, you order the Berkeley heart panel. So instead of spending $50, you spend $450. You get $400 of information that no one knows what to do with. So autoantibodies is one of those areas where there's a lot of overtesting. So the disease that's based in truth, the diseases are real. Some of them are increasing in frequency. Others are increasing in awareness. So they've always been out there, but now we're increasingly aware that they're in the population in higher frequency, but they're not in the population at the 25% level. And so these things can spread. They can spread through schools. The fixed false, and it's not just autoimmunity, it's food. Fixed false belief that all the kids have Lyme disease in a Western state is a good example. In a Western, we have very little Lyme disease in Washington State. So little that we don't even test. You know, we send it out to Mayo. Here it's very common, so it's a little bit different. So that's the context for this section. So autoantibody testing, very, very, very helpful if you're sick, can be helpful as a rule out, but it's over-tested. And it's because rare diseases have common symptoms. People Google, they bring in their list. Physicians feel pressured, so they order. Some autoimmune diseases are actually very common. They're common and have common symptoms, like celiac diseases. Patient pressure, Googleification, and also through social networking. So Google, gives you the false information you need, and then social networking allows you to spread it. So Google allows you to become an idiot, and Twitter allows you to Facebook allows you to tell everybody that you're on this new bizarro diet, or you've been poisoned by the gardener. Okay, and there's a tremendous growth in quackery, people going to Matchbox University and in Washington State, where the politics are just slightly left of Karl Marx. Anybody can hang a shingle. Everybody is hanging a shingle up and giving out echinacea, goldenrod, and garlic. Now, the irony, of course, the tremendous irony of the wellness movement, and this is it couldn't be more ironic, is that it makes everybody sick. That's the unbelievable irony of it. If you get tested, if you get these big panels, they always come back positive, so we're making people sick. And this is an example of what happens with autoimmune diseases. So here I've Googled joint pain, and I've gotten rid of the quack sites, because a lot of stuff comes up. A lot of quack sites come up. You may have, and it's usually you may be suffering from a stealth parasite infection, or you may be suffering from a nutritional deficiency or metatoxicity, or you may have an autoimmune disease. But here I've picked up the first good site that came up. In other words, a site that I would trust my relatives to, and this is Medline Plus, which is sort of the public version of Medline, PubMed. And each of these things you can click on: sprains, fractures, gout. Now you're starting to see lab tests, right? Septic arthritis, very large group of lab tests when you click here. Then just the viruses. I mean, right there you got six tests, influenza. So there's a few $100s of testing, and you don't get down to rheumatoid arthritis and lupus here. And when you hit lupus, you get the whole alphabet soup: double-stranded DNA, SMIT, SSA, SSB. And you can go deep. If you keep clicking, you get down to PCNA. You get down to some deep, deep stuff. And then you come in with that big list, because most of these symptoms of lupus and these other diseases are common, but the diseases are rare. The worst single case of overtesting in the United States now is thyroid disease. Food is up there, but thyroid is the big one. Now, one problem is thyroid disease is very common. And then the other is, if you Google a symptom, the thyroid comes up for every single symptom. There's not a symptom that you can put in that wouldn't give you a positive test for thyroid disease. So you're a little bit hot. You feel a little bit hot. It's your thyroid. You're a little bit cold. Could be your thyroid. You're gaining a little weight. You're gaining a little weight. You're losing a little bit of weight. You're anxious. You're angry. You're apathetic. You don't care about anything. You lost your appetite. You got too much appetite. You're gaining hair. You're losing hair. You're wet. You're dry. It's your thyroid. Your heart's beating a little bit fast. Stop beating at all. You're sleeping a lot. You don't sleep at all. It could be your thyroid. So the number one test in my lab in ambulatory care is TSH. That is unbelievable. More than CBCs and more than basic metabolic panels. Unbelievable. Totally driven by Google. So just to show, now I want to show you the problem with overtesting in autoantibodies. So when you overtest people with autoantibody, here's 3 people. and you say to yourself whether these people are low, medium, or high probability of having lupus. So a 40-year-old guy presents with a burning feeling on urination. He says his new girlfriend was recently diagnosed with lupus. He read about lab tests for lupus online. He wants an ANA test. And now look at this person. 40-year-old woman presents with progressive fatigue, hair loss, malar rash, oral ulceration on the inside of her lip, joint pain bilaterally, her hands, wrists, and ankles. This lady's going to have lupus, right? This person has less than a 1 in 1,000 chance of having lupus, right? And then this person's in the middle. So this is the person who lab testing helps the most. They're 41-year women. They have a month of fatigue, hair loss, so 2 common symptoms of lupus, but that are usually not lupus. But then they describe something that's of real concern, which is a malar-type rash, but it's faded. So this is where real medicine has to be practiced, and where an ANA test can help determine whether you're going to need a referral to a rheumatologist. And the problem with this is a graph of pretest probability. So pretest probability, 1%, 0.1% would be 1 in 1,000. So our guy, burning P, new girlfriend guy, he's down here. Pretest probability-wise, he's over here. But I'm going to give him a break and say he's here. Our lady with the oral ulcers and the progressive joint pain and all that, she's up here. She's a very high pretest probability. And this positive predictive value. So this is, given that the test has come back positive, what's the probability the patient has the disease? Okay? So this graph is driven by an equation where you plug in the sensitivity and specificity and pretest probability of the test. And it produces positive predictive value. And I've plugged in the typical numbers for an ANA test, which is a specificity of 85% and a sensitivity of 95%. That's what I've plugged in to get this number. And then in most labs, the specificity of an ANA IFA test is actually 68% on average in the United States, not 85%. So this is lupus on a good day. This is the ANA test on a good day performing the IFA, and look what it produces. So this means down here that if Mr. P, burning P guy, gets a positive, you can virtually assure him that he doesn't have the disease being tested for. And that's why you don't test. And that's why there's a myth about screening in the United States, because you can plug these curves in for almost any test, and most positives will be false. And that's why in the United States we've never had more tests available. When I started in lab medicine, there were 2 tests, tasting the urine and looking at it. Now I have 4,000 tests on the menu. But we have never, if you look at U.S. Preventive Service Task Force, CLSI, any evidence-based group that makes screening recommendations, we've never recommended fewer tests for asymptomatic or vaguely symptomatic people coming in for what I would call well patient screening, general health screening, population screening. And so this is why. Whereas the gal who has a positive test over here, now why is this guy positive? He's positive because you bought a new mercury arc lamp. He's positive because there's natural autoimmunity. He's positive because I've mislabeled this specimen. There's an overlap between disease and health. There's interfering substances in blood. So he's positive, but he doesn't have the disease being tested for. That other lady does, so when she's positive, you can virtually assure her. So people say, but the advantage of laboratory testing is that you can bank on negatives. In the when Mr. Burning P has a negative test, his negative predictive value, meaning the probability that he doesn't have the disease being tested for, that's negative predictive value, is virtually 100%. So these tests are valuable when they're negative, but the problem is when you do 100 of them, or you do a crummy test, like an ANA test is hard. It's a hard test. It has a high false positive rate. Eventually, you'll run into the problem of the positive, and that positive is false. And physicians very much do not understand what the curve looks like over here. They think it comes up nice like this, but it's down in the low pretest probability setting. Very few tests, even if I plugged in 95% sensitive, 95% specific, would be of any value there. If they're negative, you can rule the patient out. That's very, very helpful, but eventually you run into false positives. So in the latter part of the lecture, I want to just talk about testing principles, okay? And I'll use autoantibody testing as my example. This is the set at the University of Washington Immunology Lab where I was for 20 years. This is the current methods that are being used, and we use an ANA screen by IFA, and then follow up the testing. Most of the follow-up testing now is done by multiplexing, and the trend was that it went from diffusion, octolony-based assays, then to enzyme immunoassays, and now to multiplexing. And then for rarer stuff, PCNA, for example, we're still doing IFA, and there's still plenty of EIA around. So that's just a general trend. There's been a movement from subjective assays to objective assays and a movement towards more automated assays. That's just been our trend. Now, I list these things not because the university does it right, but just so you have comparison. And what we're doing at Seattle Children's is actually, it's a smaller menu, but it has a similar philosophy: more automation, less subjectivity, more objectivity. There's only one thing I want to mention on this slide, which is that in a kit insert for an IFA, it'll tell you that normal adults less than 60 should have a 5% false positive rate. There's just no chance. That's on a different planet than the one I'm living on. I'll show you what the actual numbers are in a second from a classic study by Tan. Okay, so what are the methods of testing out there for ANAs? IFA, EIA multiplexing. This one is shrinking. This one's holding steady, and this one is growing. And what's interesting is how little this has actually shrunk over time. Like, it's shrinking, but when I was in medical school in the 80s, I was told not to learn this test because it's going away, going to be replaced by ELISAs by the end of the 80s. Now it's 20 years later, and there's still a lot of IFAs done. And not only that, it's made a bit of a comeback because the American College of Rheumatology has declared it a gold standard. That's because they don't understand the reality of the test is done. They don't understand that you only have 2 med techs left in your department who can do it, and one only has one eye from reading it for so long, and she wants to retire, but you won't let her because you have no one else who could do that. The American College of Rheumatology is unaware of your one-eyed wanting to retire, is seeing everything green, reading 300 a night tech. Fool's gold. So, but it's made a bit of a comeback. It's considered a gold standard now. I have no idea how this test is done and how subjective it can be. So the main trend is an increase in the bead-based multiplexing assay. So this is about 10% of labs now, but it's more than 20% of assays because most larger labs tend to choose highly automated methods. Similarly, EIA, it's 25% of labs, but it's 40% of the assays in the United States. And these are just some estimates that I made. And then the technology of the future is microarrays, but there are plenty of papers on it, but there's no commercially available microarray for autoantibodies, and I don't know when there will be. And when there is, and you can test for all 80 autoimmune diseases on one chip with one specimen, that's when every single person in the United States will have an autoimmune disease, except me. Because I get tested only when I'm very, very sick. Okay, so this is the IFA. Many of you are familiar with it. These are the multi-well plates coated with Hep2 cells. This is an antigen on the, let's say a double-stranded DNA antigen on the Hep2 cell. This is the patient's autoantibody in red, and then the fluorescence conjugated anti-human antibody, which is the signaling antibody. And then this is interesting. Is there a way, Mary, to turn the lights down? I don't know. I can't see it up here if there's anything. But this is a negative. This is an endpoint control, and this is positive. So to be positive, you have to have 2 criteria. One is that you have enough intensity that you're greater than the endpoint control, and then the other is that you have a defined staining pattern. In this case, is a homogeneous staining pattern. And we may not be able to turn the lights down, but if we did, you'd see that this negative will get much brighter. That would be the point of turning the lights down. And you can see right now, yeah, so you can see that that's your problem. And then this can start getting very close to this, and that essentially is the problem with the ANA-IFA test. And then there are these patterns that loosely correlate with specific antibodies, and that correlation has become looser. Why has it become looser? It's become looser because we can't do the test anymore because everybody's retiring. And so then physicians say there is no association. In my institution, they'll say there is no association, and there isn't. And because in that institution, they started calling centromere patterns discretely speckled patterns a long time ago. And so so there's a debate about how meaningful these patterns are, but the debate in itself is actually often cast in the wrong light, because in many institutions it's still meaningful. If you have a program in place for people to call these out consistently in a way that's reproducible, those patterns can still be meaningful, especially the centromere pattern, which is highly associated with the crest variant of Scleroderma. So this is homogeneous speckled centromere, and the bear claw, which is the nucleolar pattern. And then this is titer, and titer, unfortunately, labs disagree so much. There's so much interlaboratory variation with titer that CAP doesn't have a correct titer on your CAP. There's a correct answer for positive, negative, but not for titer and pattern, because there's not enough consensus. It doesn't reach the 90% consensus. This is a patient with a 1 to 320. Here's the control. So when you titer out this patient, you know, at 1 to 320, they look like the control, so we call that the 1 to 320. It's certainly true that patients with higher titer are more likely to have a disease. You can have high titer and have a false positive from an infectious disease, but you are obligated to figure out what a patient has once they're at 640, and certainly repeat testing. It's these 1 to 40s that kill people and give us a ton of false diagnoses. And the problem with the ANA-IFA test is that it's problematic because, you know, a bunch of different things. This is photo bleaching. So I can remember when I learned this test, you know, you'd be looking at it, and then I'd be showing it to a student, and then I'd be looking at it, and by the time we were done, there was nothing left because the thing was photo bleaching, especially if you have a good lamp. And this is the area that we were just moving to. We just moved the microscope objective from here to here, and you can see this is faded. The methods are not standardized. There's all kinds of different substrates out there. They're fixed in different ways. People use different kinds of microscopes. Your lab might be well off and have a mercury arc lamp at 10 hours. Another person might be using a flashlight because they got budget constraints. It's time consuming, it's fatiguing, it becomes impossible when done in high volumes. I've visited labs that were, before they switched from IFA, were doing 300 a night, and that's so you end up having to use a low power objective and just kind of zipping through. Truthfully, that's what happens. And then to do this well, it requires a commitment to training and competency assessment. This is why many years ago we did this. We did that ANA tutor for ourselves to achieve a consistency amongst ourselves, and then it turned out to be of interest to other labs locally, and then we made it into published it as a product with Bio-Rad, et cetera. But if you maintain this commitment, if you already have this expertise, it's very valuable as an anchor tenant for your rheumatology outreach. It's gold. And once you get the ANA, then you get the rest of it. And so, you know, from a financial point of view, it's very, very good, and then you're doing good medicine. So it's hard to climb this mountain, but if you've already climbed it, you know, and you still got a few people around, you don't have to get off the top of that mountain. If you're exhausted, if everybody's retiring, you know, sure, you're going to have to move to automation. Or you have people who don't, you know, now you're going to bring it on for the first time because Google has driven you to you're sending too many out, and you're going to bring it on for the first time. You're probably not going to go to this method. You're not going to bring in the microscope. You're probably, you know, going to go to an automated method. You can turn on up the lights now. I appreciated that. And just to show you what the false positive rate is, this is a classic study from '97 where 15 different labs that considered themselves expert in ANA testing used whatever they did, whatever they used for ANA-IFA, that's what they used in the study, okay? And they took 125 normal sera, they snuck them in there blindly into these super famous labs, and they produced a false positive rate of, they produced a false positive rate, boy, there's a bullet missing here, unfortunately, of 32% at 1 to 40. So they produced a false positive rate of 32% at 1 to 40. And they have to get up to 1 to 80 to start knocking it down into the teens. And then to get to that false positive rate of 5%, you had to have a cutoff of 1 to 160. And a lot of labs running, when you go around the country and give these kind of workshops, a lot of labs have raised their titer. For example, how many people here use a titer of 1 to 80 or above as a cutoff titer who do ANA-IFA? So there's always a couple. And that makes sense because otherwise you're driving people crazy. Now in pediatrics we use 1 to 40. But remember, naturally occurring autoantibodies occur more as you get older, and in women more than men. So then I think Mary explained that the next thing that came in was ANA-EIA. Here you coat those HEP2 cells into a solid phase. Here's the antigen. Here's the patient's autoantibody, and now instead of fluorescein, you're using an enzyme that conjugates conjugated to anti-human antibody, which catalyzes a color change reaction, and these are different colors. This patient will be very positive, and then that's a negative, and then there's kind of some intermediate stuff here. And usually most kits now that are EIA for ANA use the Hep2 cell with some extra things stirred back into the soup to help get over problems with destroyed antigenicity when in the preparation. And multiplexing, which is the bead-based assay and is described, which is in the room as well. Here in one reaction vessel you have beads, and the beads can identify, so you'll have a couple of hundred double-stranded DNA beads, a couple SSA. This is a patient with an SSA autoantibody right here, and then a signaling molecule, signaling antibody here attached to it. So there's 200 SSA beads, 200 Smith. There's controls to make sure you don't have a short sample. There's some other kinds of control to make sure you don't have a lot of background stickiness staining. So, and what's beautiful about this is it's all in one reaction vessel. So instead of having to run, separate EIAs after this is all over, it's all in one reaction vessel, which is very, very nice. This is a patient with a positive SSA antibody. So, and then the anatomy of a single bead is this is the surface of the bead. This is the antigen. Let's say it's the SSA, an SSA antigen. Here's the patient's autoantibody. Here is the patient. Here's the anti-human detection antibody conjugated to fluorescein, and the way you actually detect these things is the beads, after you interact it with the patient, so the beads are either coated or they're not with the patient's autoantibody, each bead goes up in a flow cytometric column and is interrogated by two different systems. The first system, which is shown by this red laser, asks the bead, hey, what are you? What kind of bead are you? And that's based on the dye content of the bead. And it'll say, hey, I'm the SSA bead right there. I am an SSA bead. And then the second system says, are you coated? You got anything on you? You carrying? That's what this green guy is. And then you do that thousands of times. You get a statistically valid sample, and if any one of the autoantibody specificities here is positive, we call that a positive ANA. And that's essentially how multiplexing works, and it's obviously becoming part of the mix of methods for autoantibody testing and significantly impacting autoantibody testing. So there's essentially many paths up the top of the autoantibody mountain. There's no one correct way to do autoantibody testing. There are just the trends that I mentioned. But this is significantly impacting autoantibody testing, and the number of assays available is increasing. And the million-dollar question that we always get is, what should I do? And the million-dollar answer is always the same, which is, I don't know. No. But I'll give you some guidance. There's no one path, but it depends on a bunch of things, and I make all my key points in this one slide. There's more than one path to the top of the mountain, and that comes from a quote from Rabbi Eugene Markovitz, who I grew up with, and he used to say this when we'd ask troubling religious questions. He'd say there could be more than one path to the top of the mountain. So there's no true gold standard. There is no 24-karat gold standard. There's no atomic absorption spectroscopy, for an ion. We don't have that here. It's a mess. There are differences between the methods and within a method, and that's because if you look at what each manufacturer puts in the soup or on the bead, it's not the same. So we shouldn't expect that in a study they'll behave the same. The assay components differ, the cutoffs differ, and the assay quality is variable. That makes for a very confusing literature. You're going to have to do your own checkout, and you're going to have to compare it to your existing method. Now, one of the ironies of comparing it to your existing method is you might be doing a lousy job. But it's your lousy job. And your clinicians have gotten used to it. And they've relabeled your lousy job the lab that I love, what I'm used to. It's a crazy marriage. I love this lady. And those I love this 55% false positive rate. I love it because in my own mind, I've changed the cutoff to 1 to 160. That's what clinicians do. And so they've gotten used to it. So when you make a change to a better method, and it may in fact be better, they hate you for it. That's an unusual part of change management. The easiest change is when you move from what you're doing to a new method that's better for you, quicker, faster, and it kind of acts the same. Then you have no change management issues. So it's one of the ironies of improving is that people don't necessarily love you for it, and that's just the way it is. So the literature is confusing for the reasons I mentioned. It's unbelievably easy it'll happen. If you switch, you're going to find patients negative by one method that are positive by another. It's an absolute truth. It is going to happen, and you're going to get a complaint about it. But you can't manage your lab based on anecdote. You know, the plural of anecdote is not data. It's just more anecdote. And you have to look at the overall sensitivity, specificity, and then the big response to this is not to defend your method. It's not to defend it. It's to have more than one method available. If the clinical findings are not matching what your lab is producing, then test by another method. Or as I like to say in our lab, send it to Mayo. That's what I always say. Send it to Mayo. Let's see what they get. Or send it to, you know, other labs that I like. That's led to a lot of jokes around my life. Mike, then if I don't want it sent, like if I believe in the results, say you want to send it to Mayo, I say, hold the Mayo. Hold the Mayo. But you got to have more than one method. Don't rush to defend. The multiplex will sometimes give a different answer than the IFA. The IFA will give a different answer, and it can go in either direction. One's negative, the other's positive. It's just good lab medicine. This really isn't about autoantibody testing. This is what you'd always do in lab medicine. It just, you have to do it more in autoantibody testing because autoantibody testing is horrible. It's more horrible than every kind of testing, basically. Is there any testing worse than autoantibody testing? Allergy used to be worse, but maybe not so much anymore. Can anybody name testing that is worse than, I guess anything on stool is worse. Parasites are still worse. But the thing about autoantibody testing is getting better. It's actually getting better. It's getting more scientific, it's getting more automated, it's getting more reproducible. So it's getting a lot better. I thought I'd never say that, but it is. And when you switch methods, you got to communicate to care providers how the method is going to be different. And you got to remember that the ACR position, American College of Rheumatology position on IFA, is flawed. It's important. It's important because rheumatologists are doing it, and it makes you want to, if you're doing a good job on your IFA and you're servicing a lot of rheumatologists, you want to hold the line on that if you can, if people are still around to do the test. But you have to remember that this is flawed, and then you may need someone to deal with your rheumatologist, if or especially if an outreach business, and you don't have deep relations, you may need your pathologist, or if you have a crummy pathologist, you may need to get someone involved in your practice, a rheumatologist in your own practice, or a medical director. Because I wouldn't say this is an area of strength for most pathologists. If those of you working in community hospitals I don't want to impugn my colleagues, but they may have a tendency to look at anatomic pathology specimens more, just a little bit. And they may prefer billing 88305 over and over and over again, because you can buy some tremendously nice things now on the internet. There's TVs, boats with that. Whereas if they get into a fight with a rheumatologist about a particular case related to autoantibody testing, that's not very lucrative, and it's annoying. Now, that's why people hire pathologists like me, because we love it. So the main point is that since there are many paths to the top of the mountain, a lab can successfully switch to a solid phase assay if they want to, and you just have to keep in mind the things I just mentioned. One thing we did successfully when going between methods is we at the UW, we would save patients that we were following over long periods of time, and so if we switch methods, we'd re-baseline them, and then that takes away a lot of, you bank some old specimens and you re-baseline them with the new method, say your new double-stranded DNA method. That can take away a lot of fears from clinicians when you make that change. That's not the easiest thing in the world to do. In a university setting, it's the kind of thing we do. But should you implement a solid phase? And that's complex. Clearly, there's a movement towards solid phase, it's complicated. The American College of Rheumatology loves the IFA. You can have a re-education. If you're doing a good job with pattern and titer and then you take it away, people want their pattern and titer. So a lot of times people use all kinds of different ways of getting around that, like if it's positive, they'll still give them a pattern and titer. So it's complex. If you're, like I said, if you're doing 300 of them, you're going to have to go automated. If you're losing all your historical momentum because your techs are retiring, or you have no historical momentum because you're bringing on ANA for the first time, then you're going to have to go automated. If you have built a practice around IFA and you're doing a good job, you want to hold the line. The hardest thing in switching is the double-stranded DNA assay, because it's a pathogenic antibody. It's associated with the sickest patients. It's the one that's followed quantitatively in patients with lupus nephritis. And there's a lot of different assays out there, and they don't measure the same thing. So it's the same issue where they don't compare well because they don't measure the same thing. And so when you switch methods and they were following this, it can lead to a problem. And you have to know how your method behaves for that patient's double-stranded DNA. Rebaselining is the best. It's not always realistic, but that's what we like to do. And the main thing is don't defend your method. If it's not working, use a different method. Okay, multiplexing is the most automated method, period. And it will keep getting more automated, although the different multiplexers in the market vary quite a bit with regard to how much automation they have. I think the Bioplex is the most automated Luminex-based method. Bio-Rad can correct me if I'm wrong. Does Bio-Rad want to say anything negative about the Bioplex 2000? Just correct me if I'm wrong. But I actually do think it's the most automated. What do you do when the tests are positive? When the tests are positive, you have this alpha. When the ANA is positive, then we used to, before multiplexing, have to individually test for the entire alphabet soup. And this has gone from Octoloni-based assays or diffusion-based assays to EIA and now to multiplexing. But that's your choice for panels. And labs that have a solid phase assay, they have a choice. They can either report out negatives as negative, and almost everybody does that. But if they're positive, what do you do? And the conservative approach is to give them a pattern and titer. In other words, reflex to IFA. What's the problem with this? The problem is you don't get rid of your IFA. You got to bring that one person back on Mondays. That's the whole thing where you beg a tech. You've all done this. You beg a tech. Just come in on Mondays. Just read out a few on a Monday, just for a couple hours. We'll set it all up for you and everything. You just come in, read a couple out. The aggressive, though, is to get rid of pattern and titer and just do follow-up testing and only use an ANA IFA when there's some kind of discrepancy or problem and you send it to another lab. Both techniques are out there, and over time, in the beginning with EIAs, the first solid phase assay, everybody was doing conservative management except for only a couple labs. I think the one that was aggressive earliest was Henry Ford Lab. Almost everybody was reflexing so that people wouldn't get rid of their pattern and titer. Now the aggressive approach is predominating. And the beauty of multiplexing, of course, is that you don't have to do all that extra testing in most cases for the common autoantibodies. For the common ANA, you just release the results. They're already in there. And that's a lot less testing. That's just done in software. So it's just a beautiful release. If you have to do some rare testing, say for anti-cyclin or some rare autoantibodies, you're going to have to break out assays or send out. But there's, I think, 13 autoantibodies in the, is it 13 autoantibodies in the Bioplex? 13, and then a bunch of controls. So those 13 you just released, like these beautiful balloons. I'm not going to go through the literature, but it's expanding on IFA versus, it's like when I was a kid, there was like Frankenstein versus werewolf, werewolf versus the mummy. Now it's EIA versus IFA, IFA versus multiplexing. More than one path to the top of the mountain. You can be successful with any one of the strategies. I'll finish by talking briefly about, in the last 10 minutes, about rheumatoid arthritis. So this was the criteria that were in place for a long time for the American College of Rheumatology about rheumatoid arthritis. You had to have 4 out of 7 of these criteria, with criteria 1 through 4 persisting for more than 6 weeks. And you'll notice that there is a positive, number 6, positive test for rheumatoid factor. And most assays, concentrate on the IgM rheumatoid factor because that's the most common. You can have an IgA rheumatoid factor, an IgG, but the common assay commercially available is an IgM. And you'll notice anti-CCP wasn't in there. There's no anti-CCP in there until recently, and this is what the new criteria look like. I won't go through all of them, but you'll notice in the domain of serology, you get points, and then you try to get this rheumatoid arthritis score, and patients get the diagnosis if they get a score of 6 or greater, and you get points for joint pain, inflammation of the synovium, other lab tests, and then for autoantibodies, now you get a point for either RF or anti-CCP, and then you get another point if it's positive, highly positive versus negative. So now anti-CCP is part of the picture. And the main, cutting to the chase on this test, this is a test that is more specific. It's about the same sensitivity, but it's more specific than the rheumatoid factor, which is the least specific test I've ever seen in my life. And I used to have hair, and tests like the rheumatoid factor are really the hair loss tests. Because just like, people that call, what does it mean? I don't know what it means. I don't know what it means. Your patient has a positive rheumatoid factor. I don't know. They can have anything from feeling great and being in the Olympics through cancer. Those are your choices, and every disease in between. But now we have a test that's more specific, and it really, really is helpful. And the argument for testing and early diagnosis in rheumatoid factor is to prevent these crippling sequelae in the joints through treatment. And it is amazing what can be done through providing chronically good care to the patients with these chronic diseases. And you can see that the CCP, it's got about the same sensitivity as the rheumatoid factor, but its specificity is quite a bit better. And when I see a specificity of 85% for rheumatoid factor, that's like the inventor of rheumatoid factors view of it. That's like the positive view. The glass is half full view. And this is much more specific. And there's a couple of places clinically where this really, really matters. And the big one is hepatitis C. So hepatitis C is a big cause, very common. And it's a common cause of arthritis. And the problem with rheumatoid factor is it's frequently positive in hepatitis C. And that's very confusing and leads to misdiagnosis. And the anti-CCP test is very rarely positive in patients with hepatitis C. And that is in a poll of the rheumatologists that I work with, that's what they love the most, because this is where it's commonly very, very useful. And so rheumatoid, that's the thing about rheumatoid factor. False positive with and this is just a review of rheumatoid factor. Usually they're IgMs against the FC portion of IgG. Now of interest, this is pretty interesting. So at UW, the ANA is the most common. This is a monthly tally, a recent monthly tally. So this is not the outreach business. So this is my colleagues, the way they practice within UW Medicine Health System, no outreach. And so this is fairly highly managed practice. So ANA is the most common immunology test in Immunology Lab, and then rheumatoid factor is second, and then CCP is rising, but there's still many more rheumatoid factors ordered than anti-CCPs. And I'll show you the reason for that. It's fairly interesting. So anti-CCP has been around now for quite a long time. Cyclic citrullonated peptide. It's been around for quite a long time. But this is what primary care practitioners do when faced with a case of potential rheumatoid arthritis. So this is a test ordered. I just pulled this out of the computer relatively quickly. 25 cases where a primary care physician was entertaining a diagnosis of rheumatoid arthritis initially. So like initial presentation. And you can see that they order the RF and CCP in 7 of the cases, and they're still ordering rheumatoid factor only, even though every guideline is that you order both. So even after 10 years of this test being around, in a university system where this stuff is lectured on constantly, most primary care practitioners still don't know about the anti-CCP test. and that's not serving patients well. And of interest, when we do CME presentations for family practice, we use this audience response system. And the people who give the lecture, which is usually my colleague Mark Wenner, occasionally me, will ask, you know, how many of you ordered this test at rheumatoid arthritis? And they still, most of them still have never heard of it or don't order it. So that's why, you know, you'd expect the rheumatoid factor number to be and the CCP number to be closing on each other, but the gap is coming from primary care. So in finishing, the clinical lab perspective on ANA testing, autoantibody testing in general, is that the IFA is problematic, but still worth keeping in many, many labs, including the University of Washington lab. And the labs that tend to keep it, you know, are banking on it in some way. But the biggest problem are these high false positive rates, and I talked a little bit about that. There's many paths to the top of the mountain. The ACR view is important but flawed. But in the long term, better, more automated methods will prevail, but no one knows how fast. It's easy to say that robots are the future, but no one knows when those robots will dominate. Now, family practitioners like this excellent-looking man right here are not knowledgeable about ANA testing. Their perspective is different. They want the test to be negative. They want you to raise your cutoff or choose a EIA or multiplex that performs in a way that's much less sensitive and much more specific. You drive them crazy with low titer positives. Some of them have switched in their own mind and made the cutoff higher than what you are publishing. And they are going to refer to a rheumatologist at the first sign of trouble. Rheumatologist perspective, which is the last perspective I'll present, they're knowledgeable. But they're not, and they're comfortable even with the borderline interpretations, because they're comfortable saying, you have a 140 ANA, and I don't think you have a systemic rheumatic disease. I'll see you in a year, or I don't need to see you again. Sometimes they'll do something clever and retest at a lab they know has a higher specificity and then get a negative and say, oh, I don't know what that lab was doing. That's smart. That's good medicine. It is. It's good medicine. For the worried well, it's good medicine. Find a lab that'll produce a reputable lab that'll produce a negative. That's very good medicine for the worried well, which encompasses my entire extended family and friends. But they're not knowledgeable about methods. They love the ACR. So if ACR tells them that this Etzel is a gold standard, this Hugo is a gold standard, they will say it is a gold standard and buy one. They're comfortable with all the tests in the panel, and they're the ones who manage the patients with a systemic rheumatic disease. And in conclusion, so no gold standard, you should be able to explain your ANA testing strategy, including potential problems to ordering physicians. It's a very difficult area of testing, and you should have more than one method available. And when cases don't match what you're producing in the lab, you should test by another method. Anti-CCP, you may think it's common and everybody knows about it. They don't. It's a better test, but primary care practitioners still don't know about it, even though it's in the official criteria now for diagnosis. I talked about the overall trends being more automation and a gradual progression of more automated objective methods. I want to thank Bio-Rad for inviting me today. They told me I was giving a 90-minute lecture. That's a long lecture. You know, I'm earning my keep there, Yvonne. But I enjoyed being here. It's a very nice group, and I'll be around till like just around, after lunch if anybody wants to BS or ask me questions, because the one thing I bring that could be helpful if you have questions is just 20 years of total and complete suffering in the lab. I mean, I have really suffered deeply in laboratory medicine, and so if you find that helpful, or if it even cheers you up through shameful joy, I'd appreciate it. So thanks for listening and coming today.